Hello and good morning, everyone. Today we're going to discuss thyroid gland. See, okay, let's see. Hmm, I have to turn off the sounds in YouTube. Okay, so the thyroid gland originates from an origination from the floor of the pharynx under the tongue and descends down along the thyroglossal duct to its position in the neck. So, what we're going to discuss in thyroid gland today is the anatomy and physiology and the clinical aspects of anatomy and physiology, the iodine metabolism and iodine intakes, synthesis of thyroid gland, TSH, thyroid stimulating hormone, TSH receptors, and TSH antibodies, the functions of the follicular cells and the functions of the thyroid gland, and thyroid antibodies. We'll discuss thyroid binding proteins and thyroid function test. So let's start with it. And here it is. So I told the thyroid descends from under the tongue to the position in the neck. And if it fails to descend down, then it remains under the tongue. And that's known as the lingual thyroid. Now, thyroglossal cyst. Thyroglossal duct is the communication between the thyroid from its descending position originally to its position in the neck. So this thyroid duct may get infected and may become cystic. And this is in the midline and it protrudes out, it moves up if the tongue is protruded up. It's painless midline mass from foramen cecum to the suprasternal notch in the neck and becomes painful if it's infected. And it moves up. So this is the thyroglossal cyst here. This moves from under the tongue here. And this is the thyroglossal cyst. It's a central mass in the neck above the thyroid that moves up with the extension or protrusion of the tongue. Now, the treatment of this infected cyst is antibiotics plus needle aspiration. Is that the right one? Yeah. Okay, let me see. Where is that gone? The page disappears. Okay, so the treatment, we were on the treatment, and treatment is with the needle aspiration and surgical excision. So, what's the differential diagnosis of the thyroglossal cyst? Is the mnemonics is slit, sebaceous cyst, lipoma, infected lymph node, and D for termite cyst. So, sebaceous cyst has a doughy feeling. Lipoma has a slippery edges. The infected lymph node has purulent secretions, and a dermoid cyst has a cheesy secretions. And you have to differential diagnose also with the thyroid isthmus tumor. Now, anatomy of the thyroid cell. Thyroid has two lobes joined together by an isthmus, and which is in front of the second, third, and fourth thyroid cartilages. The thyroid gland is 15 to 20 grams in weight, is the largest endocrine gland that develops from is endodermal region, and it has the highest blood flow per gram of the tissue than any other organ in the body. Highest blood flow, thyroid, largest endocrine gland. And it's endodermal in origin. Of course, all the other endocrine glands, they are endodermal in origin. And so what's the blood supply? Highest blood supply, it is three blood vessels supplying the thyroid gland. This is the superior thyroid, this is inferior thyroid, and this is thyroidema. Superior thyroid is a branch of the external carotid, and inferior thyroid is a branch of the thyrocervical trunk. And the third artery is thyroidema, which may have different origins. It may arise from thyrocervical trunk, subclavian, or other, and it may also arise from arch of the aorta and runs in front of the trachea to reach the thyroid gland isthmus. The superior and inferior thyroid, they anastomose with each other, so giving a dual blood supply to the thyroid gland. So this is the blood supply. And so what are the other structure in close relationship with the thyroid glands? This is the recurrent laryngeal nerve. So this is the recurrent laryngeal nerve. That's a branch of the vagus nerve, and on the left side is winds around the arch of the aorta and uh, supplies the vocal cord. So if this nerve is injured during surgery to the thyroid, it may cause hoarseness or loss of voice. The other structure in relation with thyroid is parathyroid gland. There are four parathyroid glands attached to the posterior surface of the thyroid gland, each one on one corner. And what's the function of the parathyroid gland? It raises and it maintains the serum calcium. So how does it maintain the serum calcium? It increases the osteoclastic cells activities of the bone and removes the calcium from the bones. And the normal calcium level is 9 to 11 milligram per 100 ml. So it causes, if it's in excess, it causes brittleness of the bone. The bones become weak. So which other hormone reduces the serum calcium? This will increases the serum calcium. The other hormone that decreases the serum calcium is calcitonin. We'll come to it in a moment. So then the other structure, and a deficiency of the calcium causes tetany, which causes muscle spasm in different parts of the body, and especially of the larynx, laryngospasm, because muscle relaxation also requires calcium. When calcium is deficient, the laryngeal muscle once go into spasm, they remain so, and they may cause asphyxia and death. Bruit over the gland indicate increased vascularity. Now, what's Pemberton sign? With a large retrosternal goiter, it may cause hyperventilation, especially when the arms are raised above. The next is the role of thyroid before birth. Maternal thyroxine crosses the placenta and controls the thyroid function in the intrauterine life and is responsible for cell differentiation during the development. So a deficiency of the thyroid in the baby during the intrauterine life may cause cretinism and damage to the brain and severe mental retardation. Congenital hypothyroidism occur in 1 in 4,000 newborns, and it's a preventable cause of the mental retardation. So thyroid screening is mandatory at birth. And the other disorder which is also required to have a screening is PKU, phenylketonuria. So these two disorders, thyroid and phenylalanine screening, are mandatory at birth. PKU, phenylketonuria, is due to the deficiency of phenylalanine hydroxylase. An excess of phenylalanine in the body causes severe mental retardation. So, how cretinism causes mental retardation in the newborn babies? Thyroxine is essential for the normal synapse development, and it's also required for myelination. Normal myelination does not occur if thyroid is deficient, and the synapse development is also defective, causing severe mental retardation in the newborn baby's neonates, which is not reversible after it gets damaged. So, replacement therapy is required from the very beginning. Now, thyroid function in the pregnancy. First trimester HCG stimulates TSH receptors and may cause hyperthyroidism, transient, and HCG also causes hyperemesis gravidarum. Then placenta increases the thyroxine metabolism. So in iodine deficient areas, it may cause impaired thyroid hormone production. So what's the normal iodine intake? The normal iodine intake in an adult is about 100 to 150 microgram a day, but it's increased in pregnancy and it's 200 microgram a day. Now, follicle. Follicle is a rounded structure composed of follicular cells surrounding it with a lumen in the center. This lumen is filled with a colloid, thyroglobulin, which is produced by these follicular cells. Now, the shapes and types of the follicular cells. The shape of the thyroid gland depends on the state of the thyroid gland. In the active state, the cells are columnar, like this here. These are the columnar cells in active state. That this thyroid this lumen is small because this colloid is being used continuously. But in inactive state, the cell becomes cuboidal or flat, and the follicle becomes big because of the accumulation of colloid or thyroglobulin in it. So this is the follicle, rounded structure surrounding a lumen, and it is composed of these follicular cells. So we did this. Now, types of cell in the thyroid gland. Follicular cell, two type of cells, and the parafollicular cells are the medullary or C type of cell. So what's the function of these cells? Follicular cells produces thyroxine, and the parafollicular cells produce thyrocalcitonin, which decreases serum calcium. As we were discussing about the parathormone about a few minutes ago, that causes increased serum calcium by increasing the activity of osteoclast. The thyrocalcitonin is opposite to that, and that causes decrease in serum calcium by withdrawing calcium from the blood from the serum and deposits it into the bone. By how does it do that? It decreases the activity of the osteoclast and increases the activity of the osteoblast. So these medullary cells are interspersed throughout the thyroid substance between the follicles. Here it is. These are the two follicles here, and here is the parafollicular or C type of cell. So this is also shown here, two parafollicular cells between the follicles. Okay, the other substance that is concerned with the calcium and bone metabolism is vitamin D3, 125 dihydroxycholecalciferol. Where is it produced? The 125 dihydroxycholecalciferol is produced in the kidney, and its precursor is 25 hydroxycholecalciferol. That's an inactive substance produced in the liver from the cholesterol to 7-dehydrocholesterol, and in the liver it forms inactive 25 hydroxycholecalciferol, and then in the kidney it forms 125 dihydroxycholecalciferol, which is the active form of vitamin D and is water soluble. So kidney is also an endocrine gland because this comes directly into the circulation. So the other substance That kidney also produces, as an endocrine gland, is erythropoietin, which produces RBC from the bones, which act on the bones to produce RBC. So these two substances, endocrine function of the kidney, are the production of the vitamin D3, 125 dihydroxycholecalciferol, and erythropoietin. So patients with chronic renal failure have deficiency of vitamin D, they have rickets and also anemia. They're pale looking from a distance. So this is important from clinical point of view because the renal failure patients have rickets and vitamin and anemia due to deficiency of erythropoietin produced by the kidney. Now we come to the functions of the thyroid gland. The thyroid gland trap and transport iodine, synthesize thyroglobulin, secrete thyroid hormone, and detach them from thyroglobulin because when thyroid hormone is produced, it's attached to the thyroglobulin. We'll discuss it in a moment. And it controls the energy metabolism throughout the life, maintains BMR, basal metabolic rate, or resting metabolic rate. So BMR, what's BMR? BMR is the rate, is the amount of energy required to keep the body functioning. That's basal metabolic rate. So how does it do that? It Thyroxine increases the oxygen delivery to the tissues. How does it do that? It dissociates oxygen from hemoglobin. How? By increasing the 2,3-DPG, 2,3-diphosphoglycerate that detaches oxygen from the hemoglobin. So increases the oxygen consumption of all the tissues except which tissues? Except brain, uterus, testes, lymph nodes, and spleen. Now we go to the iodine metabolism. Iodine uptake is critical first step in the synthesis of hormone. Just give me a break for a moment. Okay, let's see. Hmm. I'll be there in a moment checking the YouTube whether it's there or not. Yeah. Okay, we are back to the topic now. Let's see, my file is gone. Okay, now we're doing the iodine metabolism. So the iodine uptake is critical first step in the synthesis of thyroid hormone, and it's the first step and is rate limiting step. So how is it done? So this is the thyroid cell, follicular cells here, which is here encircling the colloid and lumen of the follicle. And this follicular cell has two surfaces. This is the basal surface, and this is the apical surface. This is here is the apical surface, and this is the basal surface against the blood vessels and capillaries. At the basal surface, we have two important structures. This is sodium iodide symphosis, and here is the TSH receptor. And at the apical surface, we have um, TPO and pandorine receptors. So this iodide pump sodium iodide symporters, they pulse from the iodine from the blood, which is in the iodide form, sodium iodide, and takes it into the cell and maintains a concentration of iodide about 30 times more than the blood. So this follicular cell has 30 times more iodine than its capillary just running over here next to it. So then when iodine is taken up in the form of iodide, and then it goes towards the apical surface where we have hydrogen peroxide and TPO, thyroid peroxidase, which convert it to iodine. And then pendrin receptor here at the apical surface. So this is the lumen here, and this is the apical surface. This lumen, and this is the lumen, and the apical surface pushes the iodine from here into the lumen. So what happens in the lumen, that it attaches to the thyroglobulin molecule, where at position 3 to form monoiodotyrosine. Then at position 5, the next iodine goes to the position 3 and then to position 5, diiodotyrosine. So 2 diiodotyrosine and unite to form T4, and 1 diiodotyrosine and 1 triiodotyrosine, monoiodotyrosine unite to form triiodotyrosine. So this is how it's formed. After that, once the iodine is attached to the thyroglobulin, it goes back into the follicular cells. From here, back into follicular cells, because it's attached to the thyroglobulin and has to be detached from that to get out into the circulation. So when it comes into the cell, back into the cell, this is attached form. This goes to the lysosome, not shown here. Let me see if I can show you somewhere. So, oh, I think, yeah. This comes here to the lysosome. Better here. Let's see. And then what happens in lysosome, this is lysosome, that it has protease. Protease breaks the bond between thyroglobulin and the future thyroxine. So once the bond is broken, this bond is broken, this is thyroxine here, this thyroglobulin goes back into the lumen here, from here back to the lumen. So this cells exudes the thyroglobulin out, and that goes into the lumen, and the thyroxine T3 and T4, they are exuded out into the circulation, right? So this is how it goes out. This is how, so this is the iodine metabolism, the basal surface. We have this iodine, sodium iodine symporters, and this symporter is stimulated by TSH. TSH comes here at the basal surface. We have TSH receptors. So this attaches to the receptor, and that stimulates it to increase the iodine uptake from the circulation. Then at the this TPO converts it into iodine form, and then this iodine attaches to the 3 position, 5 position, 3 position of the thyroglobulin to make T3 and T4, and that then it comes back into the cell, and then it goes into the lysosome, where proteases breaks the bond between thyroglobulin and a future thyroxine, and then thyroglobulin goes back into the lumen, and T3 and T4 go out into the circulation. So this is the whole process of iodine metabolism and its trap. Trap is important because the follicular cells maintains an iodine concentration of about 30 times than its concentration in the blood. Okay. So we did thyroglobulin combines with tyrosine to form. Okay. So this is the structure of the T3 and T4 and T5. This is T3 in the middle here. Monoiodotyrosine at T position, 3 position, then 5 position, and 3. So T3 is 353. And T3, we'll discuss in a moment about T3 and T form. So T3 form from MIT plus DIT and T4 by the DIT and DIT. So into the cell lysozyme, we discussed the lysosome. Then in the lysosome, we have protease that breaks the bond here between the thyroglobulin and the thyroxine. And this is the TSH receptor here, where TSH comes and attaches and stimulates this sodium iodide symphotus. And then iodide is converted to iodine. The other organ that competes for thyroxine, for iodine, are lactating mammary gland, salivary gland, and the uh, kidney. So these three organs they also compete for iodine, but follicular cell of the thyroid maintains the concentration more than 30 times than the blood. A deficiency of the iodine, what does it cause? It causes endemic goiter and may cause cretinism. Cretinism causes mental and growth retardation, and a mild iodine deficiency causes decrease in IQ. Another element, selenium, concomitant selenium deficiency may also cause mental malfunctioning. So, iodine and selenium. So, what are the effects of iodine deficiency on the thyroid gland? Iodine deficiency leads to goiter formation, enlarges the thyroid, increases its size, increases its blood supply, its blood flow. It causes hypothyroidism and cretinism, increased blood flow. The iodine deficiency also stimulates the sodium iodide symphotus so that it stimulates more efficient uptake. So, and then we have active transport of iodine is stimulated by TSH, as I already explained. The TSH attaches to the TSH receptor and stimulates the sodium iodide symphotus. And sodium potassium ATP is also stimulated, and its active transport is inhibited by ubane. So, what's the treatment of the iodine deficiency? It's iodine, not thyroxine. Iodine deficiency corrected with iodine. And iodine binding to tyrosine, because it attaches to the tyrosine molecules to make the thyroxine, is blocked by anti-thyroid drug propyluracil thiouracil. Now let's discuss the difference between the T4 and T3. T4 is produced more than T3, about 80 microgram a day, whereas T3 is produced about 4 microgram a day. So a difference of 20 is to 1. But T3 is more powerful, strong, and it's 4 times more potent than the T4. And T4 is converted to T3. T3 is less tightly bound to the proteins, so it's more active than biologically active than T4. When T3 is used, T4 is converted to T3 by deiodinase enzyme. There is deiodination of the T4, so T3 becomes available because one tyrosine is removed from that. So this is the structure of T3, 3, 5, 3. Iodine attached to the tyrosine here. This is position 3, 5, 3, triiodotyrosine. And RT3, reverse T3 is 535. Okay, and it's inactive form. 99.7, in 98% of the thyroxine, T3 and T4 are protein bound. And it's a free form which is physiologically active. And this inhibits the TSH secretion. We'll discuss in a moment. Free thyroid hormone in the plasma are in equilibrium with the protein bound thyroid hormone in the tissues. So when a free form gets reduced, the bound form releases the free form. T4 is converted to T3 by the enzyme deiodinase. So this is important. Conversion of T4 to T3. There are certain conditions that decrease the conversion of T4 to T3, drugs and disorders. Drugs that decrease the conversion of T4 to T3 mnemonics is GAP, glucocorticoids, amiodarone, propranolol, and propylthiouracil, GAPP. And the disorders that decrease the conversion of T4 to T3 are trauma, tumor, burns, anything that reduces the body metabolism, concerned with the body metabolism. And these are trauma, tumor, burn, cirrhosis, liver, kidney failure, and myocardial infarction. So cachexia, malnutrition, any condition that causes decreased supply, that reduces the T3 because T3 fall conserves the calories that leads to decreased nitrogen oxygen and decreased nitrogen excretion. So this is the advantage of reduced plasma T3 in conditions of cachexia and malnutrition and other debilitating disorders. So then T4 and T3 are deiodinated in the liver and kidney and are conjugated to form sulfates and glucuronide and enters the bile and pass in the intestine. And T4 and T3 are measured by radioimmunoassay. Now, control of the thyroid function. So, this is the thyroid gland here at the bottom. It produces thyroxine that acts on both the pituitary and the hypothalamus. Hypothalamus produces TSH release hormone, and pituitary produces TSH to act on the thyroid to produce thyroxine. So this is how TSH acting on thyroid. But when these thyroid hormones are produced, T3 and T4 act both or act on pituitary and hypothalamus to reduce their products, the TRH and TSH. So it's a negative feedback inhibition of the thyroid hormone by the hypothalamus and mainly by the pituitary. TSH is decreased by negative feedback. So this is, yeah, by negative feedback, decreased by negative. And dopamine. TSH is inhibited by T4 and T3 as and other dopamine, stress, heat, somatostatin, and HCG. These are the substances that inhibit the TSH. So what if there is decreased TSH level? The TSH levels are decreased in thyrotoxicosis and first trimester pregnancy. And any severe non-thyroid illness may also cause abnormal TSH levels. So what's the mechanism of action of the thyroxine? T4 is converted to T3, as I already told, by deiodination when it is needed. T3 then enters the nucleus and binds to the DNA and causes synthesis of mRNA. So T3 entering nucleus bind to DNA causing mRNA synthesis, then mRNA dictates the formation of proteins in the ribosome, the same formula of making protein synthesis. Now thyroglobulin. So thyroglobulin is a large glycoprotein molecule produced by the follicular cells and secreted into the lumen as a colloid by a process of exocytosis. So, what's the main role of thyroglobulin measurement? Thyroglobulin measurement main role is in the follow-up of thyroid cancer treatment. It's not for thyroid cancer diagnosis. It's used to check for the level of thyroglobulin after the thyroidectomy for cancer or radioablation, because a presence of thyroglobulin after thyroidectomy indicates, what does it indicate? It indicates either the removal was incomplete or there is recurrence. Ablation was incomplete. So this is how, because TG is produced by the thyroglobulin is produced by the thyroid. So if there is some tissues left, they keep on producing thyroglobulin. So normally it should not be detectable after thyroidectomy. So it should be less than 1 nanogram per ml, but it may be between 1 to 10 nanogram per ml. So cytology should be checked. And then the value above 10 nanogram per ml suggest malignancy. So what are the conditions that we have the high TG level with estrogen increase in uh, high thyroglobulin levels occur in thyrotoxicosis and thyroiditis with a normal concentration of 6 nanogram, and low thyroglobulin level occur in thyrotoxicosis, factitia, and liver failure because the liver makes globulin, and thyrotoxicosis factitia is the only one where thyroglobulin is low. Otherwise, in all thyrotoxicosis, the thyroglobulin levels are high. So thyrotoxicosis and also in thyroiditis, thyroglobulin levels are high. It falls in the liver failure. Now, thyroid binding proteins. Three thyroid binding proteins: thyroid binding albumin, thyroid binding prealbumin, and the thyroid binding globulin. The main protein with which the thyroid binds is thyroid binding globulin. It binds more than 80% of thyroxine. Only 10%, roughly approximately albumin and prealbumin are bound to the thyroxine. But thyroid binding globulin, with which thyroxine is bound by 80%. So main is that. Albumin, as you know, is the largest, and globulin is the smallest. Albumin level is 3.5 gram per 100 ml, and globulin level is 3.5 milligram per 100 ml. Okay, so 98% of the thyroxine is protein bound, and it's a free form which is physiologically active, and this inhibits the TSH production, right? Increased thyroid globulin, also thyroid binding globulin. Thyroid binding globulin occur in estrogen and in pregnancy. When there is excess of estrogen in pregnancy, thyroid binding globulin increases. And when does it decrease? It decreases in with anti-estrogens, and with androgens, glucocorticoids, and L-asparagines. So thyroid binding globulins increasing in pregnancy and with estrogen therapy, and decrease with anti-estrogen and androgens. Okay, so as I already explained, T3 is less tightly bound, more physiologically active, more available, more potent than T4. A sudden rise in the binding proteins, what will it do? It will bind to the thyroid hormones so that stimulates the TSH secretion. Increased TBG, increased thyroid binding protein will increase the TSH because the binding proteins will bind the free forms that will inhibit the uh, inhibitory effect on TSH production. Pregnancy and taking estrogen increases TBG, and then abnormalities of thyroid binding protein. There may be a XL deficiency, X-linked deficiency of TBG, or there may be mutation in the TBG that leads to increased binding and normal hormone bind levels, a normal TSH. Now let's discuss the TSH. In this, we will discuss TSH receptors, and TSH antibodies. I'll discuss it mutation in the receptor later. So TSH, where is it produced from? TSH is produced from the basophil cells of the anterior pituitary. So what are the other hormones produced by the basophil cells of the pituitary? They are ACTH, FSH, and LH. And what are the hormones produced by the eosinophil cells of the anterior pituitary? They are growth hormone and prolactin. And posterior pituitary is just a storage side of oxytocin and vasopressin, ADH. We already explained it in another video on some bear other. Then we come to this TSH. Then, when produced by the anterior pituitary, what does it do? One thing. And okay, okay, we were here. There was some interruption. So the produced from TSH, and TSH is controlled by the hypothalamus, which produces TRH, TSH release hormone, right? So where does it act? So this is the basal surface. Here we have TSH receptors. TSH attaches to these receptors and stimulates it to this sodium iodine importers to pull more iodine in to produce more thyroxine. So TSH structure has two alpha and beta chain. Beta chain is unique to TSH. Alpha chain is like other glycoproteins. So there may be a mutation in these TSH receptors. It may be a negative mutation or a positive or dominant mutation. If it's a negative mutation, it causes thyroid hypoplasia and congenital hypothyroidism because there is a mutation in the receptors. It won't fit with the TSH connection. And then if there is a dominant mutation in the receptor, then it causes hyperthyroidism and thyroid hyperplasia. So this is the TSH mutation. And then we go to TSH antibodies, two types of TSH antibodies, TSH receptor antibodies. TSH-SI is stimulatory immunoglobulin, TSH is stimulatory immunoglobulin, and TSH inhibitory immunoglobulin. TSH stimulatory immunoglobulin causes hyperthyroidism, and it's present in the Graves' disease and thyrotoxicosis. TSH inhibitory immunoglobulins, antibodies, they cause hypothyroidism and present in Hashimoto's thyroiditis. So then TSH, what's the effect of antithyroid drugs on the TSH? TSH remains suppressed for months with treatment with antithyroid drug. Therefore, it doesn't provide a sensitive index of the treatment. When TSH suppression is alleviated, only then TSH levels can be used to monitor the therapy. Increased TSH increases the thyroid hormone. So thyroid hormone resistance, and this occurs in TSH producing pituitary adenoma. If there is increased TSH production, it will produce increased thyroid hormone. So then we need to do investigation for TRH production from hypothalamus and MRI and a scan of the brain and pituitary. TSH is the most useful marker of the TSH is the most useful marker of the thyroid function. Single test of TSH is enough to assess the thyroid activity. So if there is increased TSH, there is hypothyroidism. And if there is a decreased TSH, then it's hyperthyroidism that decreases negative feedback inhibition of pituitary TSH production that causes decreased TSH. An abnormal TSH level is an indication for measurement of thyroid hormone in the circulation. So let's see different conditions where TSH, TRH, and thyroxine increase or decrease. So if there is an increased TSH release hormone and all that will cause increased TSH, and that will cause increased thyroxine production. And so the defect is in the hypothalamus above, because TSH release hormone is is not inhibiting because of increased thyroid, which causes negative inhibition of TRH. But TRH is autonomously produced by the hypothalamus, so the condition is increase the hypothalamus. Second condition, if TSH increases, it will increase the thyroxine, but thyroxine with negative feedback will lead to decreased TSH release hormone. So in this condition, the condition is hyperpituitarism. So in hyperpituitarism, a pituitary adenoma producing TSH, there is increased TSH and increased thyroxine. And in that case, this may become multinodular goiter also. Otherwise, it's homogeneous because of increased production of insulin-like growth factor. Now, the next condition is if there is decreased TSH, that will cause decreased thyroxine. And if decreased thyroxine, that will cause increased TRH. So, in this case, when TRH is increased, TSH is not increased. It should be. So this is due to hypopituitarism, because pituitary is unable to produce TSH despite stimulatory effect of TRH. So decreased TSH and decreased thyroxine occurs in hypopituitarism. And the next condition, if TSH is increased and TSH RH also increased, TSH release hormone and TSH both increased, but thyroxine is decreased. So this is due to hypothyroidism, because when thyroxine is decreased, the hypothalamus produces release hormone and pituitary also produces increased TSH, but thyroxine is not responding. Thyroid is not responding. Next condition, if there is decreased TSH release hormone, but increased thyroxine. So now thyroxine is increased. So inhibitory effect on those causes decreased production of TSH and TSHRH. So this is due to hyperthyroidism, autonomous autoimmune bodies that causes hyperthyroidism. So what happened to TSH in diffuse goiter? In Graves' disease, TSH is decreased and and thyroxine is increased, right? And in pituitary adenoma, TSH is increased and thyroxine is also increased. So in pituitary adenoma, both TSH and thyroxine increase, but in Graves' disease, only thyroxine is increased. TSH is decreased due to negative feedback inhibition of TSH and TRH. Yeah, I just already explained it. A rise in binding protein decreases the free thyroxine hormone, and that increases the TSH secretion. Now, what are the effects of increased TSH? Increased TSH causes cell hypertrophy and hyperplasia in the thyroid, increase the weight, increase the size, causing goiter, increases the blood supply to the thyroid gland, and increases the blood flow to the thyroid. So, what are the causes of increased thyroid TSH? Increased TSH occurs when there is increased TRH, thyroid release hormone, or in cold it increases. It decreases in heat, or decrease when there is increase. Sorry, when there is decrease in thyroid hormone, when goiter is produced, when there is a sudden rise in binding protein, that causes increased TSH. So increased TSH occurs with TRH, cold, decreased thyroid hormone, goiter, and sudden rise. Hyperthyroidism is the most common cause of pituitary adenoma producing TSH. Now, suppressed TSH levels occur in thyrotoxicosis. With suppressed TSH, with normal unbound T4 levels measure the T3. So when the TSH is suppressed, you need to measure T4 and T3 because in some patients the T3 is in hyperthyroidism. The T4 confirms the diagnosis of hyperthyroidism, but 5% patients have increased T3. So you have to measure the T3 also. Let's see. So these are the thyroid antibody, TSH receptor antibodies. We already discussed two types, stimulatory immunoglobulins found in the hyperthyroidism and inhibitory, the second antibodies that inhibit the thyroid TSH receptors are is inhibitory immunoglobulins and they're found in hypothyroidism. They cause hypothyroidism. Now, thyroid antibodies, TPO, thyroid peroxidase antibody, thyroglobulin antibodies, and TSH receptors antibody. We will again discuss it. So let's discuss the TPO, thyroid peroxidase oxidase antibodies. They are most common. And the thing is that these thyroid peroxidase antibodies are present in both hyperthyroidism and hypothyroidism. In Hashimoto's thyroiditis, TPO are present. And also in Graves' disease, the thyroid peroxidase antibodies are present. Almost all patients with autoimmune hypothyroidism and 80% with Graves' disease have thyroid peroxidase antibodies at high levels. How many patients have TPO antibodies? All patients with hypothyroidism and 80% with the Graves' disease. Then we have the, I already discussed TSH receptor antibodies, two types, TSI inhibitory immunoglobulins found in hypothyroidism causing uh, stimulatory, they are found in hyperthyroidism, and inhibitory immunoglobulins, they are found in hypothyroidism. Then we have TSH receptor antibodies. I already discussed it. Okay, TSI antibody, stimulatory immunoglobulin, they enter the neonate in the intrauterine life and they cause neonatal thyrotoxicosis. So TSI can cross placenta, thyroxine crosses placenta. So if the mother has hypothyroidism, it may cause neonatal thyrotoxicosis. And now antibodies in Graves' disease. What are the antibodies in Graves' disease? TSI, thyroid stimulatory immunoglobulins, and TPO in 80% of cases. Now the thyroglobulin antibodies. Presence of thyroglobulin antibodies indicated damage to the thyroid gland and Hashimoto's disease. Normal value 1 to 10 nanogram per ml. Now, thyroid ultrasound. Thyroid ultrasound is the method of choice to accurately determine the thyroid size. Ultrasound accurately determines the thyroid size. So, what are the advantages of the ultrasound? The ultrasound localizes the nodule accurately, diagnoses the nodular thyroid, detects the nodule and cysts more than 3 millimeters. It helps in selection of nodule in multiple nodules, and it helps in accuracy of sampling. Ultrasound is useful for aspiration of cystic lesion, FNA biopsy, fine needle aspiration biopsy, that decreases the rate of inadequate sampling and used in evaluation of recurrent thyroid cancer. So these are the advantages of the ultrasound. Localizes nodule accurately, diagnoses the disease, detects the nodules, multiple nodule. You can select the correct nodule to select it for biopsy, and it's useful for, you can aspirate the cystic lesion because of ultrasound guidance, and fine needle aspiration biopsy is very helpful. Then what are the sonographic? characters suggestive of malignancy. The sonographic characters suggestive of malignancy are microcalcification. I'll show you everything. Increased vascularity, hypoechogenicity in the nodules, and the nodules have thick, irregular borders, chaotic internodular vascularity. Let's see that. So these are the ones. This is hypoechogenic nodule in the cancer. This one is a cystic, dark red, dark black, jet black, cystic lesions. This is the microcalcification here. See that? Microcalcification. So hypoechogenicity, cystic lesion, jet black, and this is microcalcification. Then this is irregular borders, and these two are coarse calcification. These are the features seen on ultrasound, helps in diagnosing the disorder. Now the next topic is thyroid scan and uptake. So what's the difference between the thyroid scan and uptake? The thyroid scan determines the size, shape, and position of the thyroid gland. It sees overactive or underactive parts in the thyroid gland. This is what a thyroid scan does. So anatomy, size, shape, and position, and the activity. Whereas radioiodine uptake, or AIU, that evaluates the function of the gland. Okay, radioiodine uptake tells you the function of the gland. A scan tells you the anatomy, the size, shape, position, and the activity of the gland also. The radioactive iodine tracer detects the cancers. What does it do? Cancer, trauma, infection, and other disorders. And what's the difference between a hot nodule and a cold nodule? Hot nodules or toxic nodules are autonomous, and they take more tracers, whereas cold nodules do not absorb the radioactive iodine, and 5% of them have the cancer. So this is the cold nodule here, taking less radioactive iodine. And this one is a hot nodule, taking more. This nodule is more actively taking radioactive iodine. So radioactive iodine uptake is done for follow-up of thyroid cancer after thyroidectomy ablation using iodine 131. A decreased radioactive iodine uptake in thyroid bed occurs, may increase or may be decreased depending on the condition. If there is a damage, if there is cold nodule, then it doesn't take it. Thyroiditis, it doesn't take it. Now these are the different conditions here. We have this is the normal uptake. This is grave disease, homogeneously hyperactively taking the iodine, right? Radioactive iodine is taken in the grave disease homogeneously by the gland, both sides together in grave disease. This one is multinodular, taking that, and this last one is toxic adenoma. So this is hot nodule, this is toxic hot multinodular goiter or multinodule. This is the normal with the cold, and this is the cold nodule, non-toxic cold nodule, but 5% may be converted to malignancy. So let's repeat it here. I repeat whole thing. So this is the ultrasound, hypoechogenic nodule. This is jet black cystic. This is microcalcification here, and this one is irregular border. These are the features seen on ultrasound. Very effective. And these are the coarse calcification. Then we have the iodine uptake, scan and uptake, and this is the cold nodule. Compare it with the normal. This is the normal uptake by the thyroid gland, and this is a cold nodule. This is a hot nodules, right? Taking more radioactive iodine. Then we have grave disease, homogeneously taking the radioactive iodine excessively. This is the normal, and this is multinodular goiter, and this is single hot nodule, toxic adenoma. Then we have thyrotoxicosis, and these are serious. They are not equal here. The uptake is not taken equally. Now, radioisotope uptake selectively transport thyroid gland selectively transport radioisotope of iodine 123, 125, 131, and technetium 99. So, what do we see on nuclear imaging of the grave disease? I already explained. Homogeneously increased stressor uptake. Sorry. So, in grave disease, it takes homogeneously increased stressor uptake and non-toxic single and multiple nodules. So the non-toxic nodule may be single or they may be multiple or cold nodule also called. They have low stressor uptake. Let me show you again. This is cold nodule, maybe multiple. Here it's only one. So showing less cold nodule, taking up less iodine. Okay, where is that? Where were they? We were not there. Okay, grave disease, they're non-toxic, have low stressor uptake. So when do we have a low stressor uptake? We have a low stressor uptake in cold nodule, carcinoma, thyroiditis, and thyrotoxicosis, factitia. Low stressor uptake. Cold nodule, carcinoma, thyroiditis, wherever there is damage to the cell, right? Thyroiditis, damage to the cell. Thyrotoxicosis factitia is different than the thyrotoxicosis, where we have excessive uptake. But this one, thyrotoxicosis factitia, is the only thyrotoxicosis that takes low stressor element, low stressor uptake. In subacute thyroid, any condition, thyroiditis, any thyroiditis, low stressor uptake. Cancer, low stressor uptake. Stressor uptake is excessive in thyrotoxicosis, except thyrotoxicosis factitia. Toxic adenoma, take more. Toxic multinodular goiter. In that, the architecture is distorted and there are multiple areas of relatively increased or decreased stressor uptake. And now for the day, I think it should be done. And we've been for almost more than 1 hour today, and the next we'll go on further clinical. But this one was important because all those clinical findings, the features of a scan and radioactive iodine, the features of ultrasound. So these were all very important to know, and they help in exam and clinical practice as well. So now I think we should be done for the day, and we see you next time. Continue with the thyroid gland, its different disorders like grave disease, the functions of the thyroid hormones, and the Hashimoto's thyroiditis and other cancers. So for now, goodbye and see you then. Bye.